Okay, I make it 11:30. Welcome back, everybody. Tracy, are you on the line?
Yes, I am, Steve.
Hi, Tracy. Now, we're going to have a little video clip, I think, from you that Steve is responsible, that Peter's responsible, I think, for putting on. So by way of introduction, then, Tracy, this is the first time we've had a kind of discussion about the BFF programme at a public board. So there'll be a video. So the plan is for a video and then an opportunity for some questions later. Is that right?
Yes, it is. Thank
you.
You,
so over to you then.
So the piece, I'm just going to show the video, and it's a video of Joe just introducing the programme, and we're really excited to have been listed as part of the government's 40 hospitals investment in our infrastructure, and we are calling our programme the Building for Our Future programme, and Joe will summarise really succinctly what we're trying to achieve. So if we show the video, and there is a presentation in the pack which is just there for information, but happy to take questions after the video. That's okay.
We're delighted that the government has announced that East Sussex Healthcare NHS Trust will be part of the second wave of funding earmarked to improve hospital infrastructure. This is an exciting time for healthcare in East Sussex. Our hospitals at Eastbourne, Bexhill and Hastings are ageing. We need to make sure that our buildings are fit for the future, that they meet the needs of our changing population, and they keep pace with the changes and improvements in healthcare. Primarily, this is a clinically led programme. We want to design improved buildings that fit around the way that our clinicians deliver services. In doing this, we hope to better meet the needs of patients. Our plans are extensive, a mixture of new build and refurbishment for our 3 hospitals. We are planning to expand our emergency department at Eastbourne and Hastings, improve access to cardiac and ophthalmology facilities, and redevelop outpatients, theatres, endoscopy and diagnostic services. Alongside this, we will create additional wards and improve parking facilities. Whilst an investment of this scale is substantial, we will need to work with our healthcare professionals, partners, patients and local people to prioritise where this money is most needed, or where it will make the biggest difference. We are at the very early stages of the development that we hope will be complete before the end of the decade, and we would like to hear from you to help shape our plans. This is a once-in-a-lifetime opportunity to transform the environment in which we provide care in East Sussex.
Thank you for that starring performance, Joe. So let's open this up for questions. Let me just kick off, and I'm mindful that we've got I think Liz probably in attendance today. What does the programme say about the disposition of or likely to say about the disposition of services, including those that have been subject to consultation in the past? Because I know that will be on some people's minds.
Sorry, Steve, I was just slightly off put by the chat bit, so I'll just delete that. Was that question to me? Sorry.
Yeah, it was.
So I think what we're not expecting to do within the context of BFF is to do some major configuration other than services that we've already talked about in terms of ophthalmology and cardiology, and they will be subject to, so we're in engagement stage for cardiology, and we will take that forward a little bit more with ophthalmology, and then should we go to public consultation later in the year, then that'll be the case. That doesn't mean, I think, and I'll come back to maternity in a minute because I know there's likely to be a question later on that. That doesn't mean that we wouldn't So, for example, if we looked at day case, we may want to do more day case on one site than the other. We wouldn't look to put all of our day case onto one site, because it becomes really, it's not a very productive way of running theatres, day surgery. So we might want to change the balance of a few things to make best use of the resources that we've got, but we're not anticipating any major reconfigurations other than the two that I've just talked about. I will just bring maternity up, and I know Liz, I think she's on the line. She is. I know that Liz, on behalf of the Save the DGH, they are particularly focusing on their feedback is around maternity, and I think being open about that, they would still like to see obstetric services return to Eastbourne. Just what I have said is that we will undertake a review of the original case for change and see if anything has changed in terms of the workforce, the birthing numbers, and any new models of care. But just to set expectations, that does not mean that we would change that service delivery model, and it's not that I'm expecting to change that delivery model, because we've obviously looked at that on a continued basis over the last few years. But I have committed to doing that as a one-off exercise, and we will share that in due course. But no, I'm not expecting any major reconfigurations other than ophthalmology and cardiology subject to consultation. Does that answer the question?
Yeah, it does. It does. Thank you. So, any questions from board members? No. Okay. Thanks very much, Joe. That moves us on then, Steve, to the winter flu self-assessment. I know you've touched on this earlier in your report.
Yeah, thank you for the opportunity to present this report. I think the report is self-explanatory, but there are just a couple of brief points I want to make or emphasise. The first is that we've now stopped giving flu vaccinations in line with the national guidance in preparation for staff COVID vaccination. So the flu vaccinations for this year are now on hold. If I look at our performance this year up to the end of November, it's similar to our uptake for the entire winter up to the end of February for last year. So for last year, that was through to February 20. Our overall performance was 87%. We're now at 82% as at the end of November this year. For comparison, this point last year we were at 51%. So if I do a like for like year on year, last year 51%, this year 82%. That's a massive amount of work, as you can probably imagine, for everyone that's been involved in the vaccination programme, and it's a great commitment shown by all of our staff during this year to come forward and have the vaccination. So I do want to put on the record, thanks to everyone for actually the incredibly hard work they've done in delivering this far more rapidly. When you look at the chart on the second page of the report, the mix of take up actually looks slightly odd compared with previous years. The numbers have moved from the chart there, which actually shows 73%. We are at 82% now. But
You've gone on mute, Steve.
So I don't know what happened then. I automatically went on to mute by itself. The mix does look different this year. It looks like this is accounted for by the introduction of an electronic self-reporting system this year, where it appears a number of HCAs, healthcare assistants, have reported themselves as nurse or in the other professional qualified group. And this is clearly something that we're going to need to fix going forward. If I look at the performance at the end of November for nursing and for other qualified professionals, they're both over 100%, which actually goes to show, I think, that where people have classified themselves is wrong. So what we will do is, as part of the wash up for 2020, we'll review the system. We'll make sure there's clearer instructions for people as to where they classify themselves. But if I come back to the headline is the overall is correct. The latest as at the end of November, or at the end of the programme for this year, is 82%, which I think is a good performance given that we're closing in November.
Great. Thanks very much, Steve. Questions from colleagues? Jackie.
Thank you, Steve. For people who elect not to have the vaccine, if they then have high levels of sickness, how do we manage that?
We would manage that in that firstly, we can't force anyone to have the vaccine, clearly. If someone has high levels of sickness but has elected not to have the vaccine, we would manage their sickness absence in the same way we would for anyone else, Jackie. So, if they're getting high levels of sickness, they would receive A, the support they need, B, the guidance they need from occupational health around managing that. So that may lead to some people deciding actually that they do want the vaccine.
I've had an example. When I was in Canada, that you had to have a sticker on your ID badge saying you had had the flu jab, and if you hadn't, for whatever reason, you couldn't work in a clinical area, and that focused people's mind and obviously gave a high level of protection in clinical areas. And it was a bit draconian, but we do want people to have this, don't we?
We do. Vicky.
Yeah.
Vicky, do you want to just come in?
It's a very, very difficult issue. I think people will obviously have their own views about, whether that's about being vaccinated, being tested, and many other things. People have their own views for their own reasons. So I think all I would say is that I would agree with Steve, that this is not mandated in this country yet. I'm absolutely aware of some of the things that are in place in healthcare in the States. I have colleagues that work there, and it is a very different approach and a different process. It's not the same in the UK, clearly, as to whether or not that will change going forward. I don't know. We've never clearly mandated the flu jab, and I've worked in various trusts where compliance is really variable. In some trusts, staff are more concordant than others for a whole variety of reasons. So I'm not aware that we treat our staff any differently if they don't have the flu jab and then develop flu. I think it will be wait and see after the pandemic as to whether or not anything changes. But at the moment, it is optional for staff.
Thanks, Jackie. Thanks, Vicky. No other questions on that item? Good, thanks very much, Steve. Let's move to agenda item 11, and we've got a number of reports to review and to note, and I assume all of these will have been through and been scrutinised and approved by the various subcommittees. David, anything you particularly wanted to say about the Q1 learning from deaths report?
Just to say that we're starting to get through some nosocomial infections from COVID, and so if you look at the graphs on the second page of my report, the two possibly avoidable cases involve nosocomial infection. However, both these cases were elderly, very frail, and were felt unlikely to leave hospital in any case. And so, although they then did subsequently become positive with COVID, it wasn't felt to have definitely changed the outcome. And we'll talk a bit more about COVID and so on in part 2. But that's all I wanted to say.
Great, thanks, David. Infection control, Vicky, anything to add?
Nothing specifically from me, Chair, for actually all of those 3 annual reports, infection control, complaints and safeguarding. Infection control, I've asked to meet with Lisa, our head of infection control, and the governance team, just to see if there's anything else we can do with the Assure system. And there's some challenges there in terms of data and the hand hygiene audits. So I've asked for a meeting there. But nothing specifically from me from an infection control point of view. And as Jackie says, we had a considerable discussion, and the pandemic really was just starting to hit in Q4. So our next annual report will focus quite considerably, I suspect, on COVID as well as our other infections. But no, nothing else from me, thanks.
Or complaints and safeguarding? No.
No, just to note, we'd had a discussion at a previous board about some of the minor changes that we made in terms of response times, but overall, no particular concerns from me. And similarly with safeguarding, we talked about some challenges in the service at the moment due to some vacancy and some sickness. But we're supporting the team, and again, just to thank the team. It's been another busy year, but no specific concerns from me.
Okay, thanks very much. Thanks very much, Vicky. Item 12, just to note the dates for board meetings in 2021, and you'll notice that we've moved the meeting dates forward slightly by a week to give a bit more preparation time for papers. So to note those, to note the use of the trust seal. And then to agenda item 14, questions from members of the public that have been asked to submit in advance. I understand, although I've not seen them personally, that we've had a very detailed set of questions in from one of our regulars, Mr. Campbell, and I think Lynette, the plan is that a kind of comprehensive or composite reply will be sent directly to Mr. Campbell on his questions, a lot of which seem to centre around the operation of block contract funding and the rules and so on around all of that. But anything you want to say just about those questions, Lynette?
Is it okay, Steve, if perhaps I'll just ask a couple of them on his behalf, and because they may be of interest to other members of the public. So the first ones are around building for our future, and he's asked whether we have looked at recent other hospital new builds in the UK or anywhere else to identify best practice and to make sure that there's learning applied by us.
Yeah. And what was the second one before we come to that?
And then the second one was, does the Trust currently follow up on discharged patients to ensure that the expectations of action by other care providers and included in their discharge plans have taken place? So it's around discharge and how we follow up when somebody leaves our care. Sure.
Joe, I don't know if you want to take the first one or whether you'd like Tracy to mention it.
Well, if I just start and see if Tracy wants to sort of fill in any gaps, really. So at a high level, we're obviously engaged with health planners and with NHS England, and as part of that process, we are linked into the other HIP programmes and are taking advice and seeking contact around best practice. I think Tracy has also been in contact with some trusts directly. So yes, we are taking that into account. Tracy, did you want to add anything?
Joe, we are learning lessons from other trusts, but I know Chris is on the call as well, and Chris has had conversations with the other organisations and directors of estates and facilities on the lessons learned. Chris, did you want to add anything more?
Just to say, Tracy, we've got a formal structure by project speed from NHS E&I, which will be where we learn of, if you like, on a more formal basis. And as you said, we've got informal links to a number of other organisations through our own network and also from our advisors who were doing other advice on other HIP projects, if that does that make sense.
It does, and I mean it's the specialist advisors where the particular responsibility rests to bring forward to us the latest thinking and the latest guidance and the latest advice, I think, isn't it?
Absolutely, Steve. But that's where also our informal networks help that as well.
Yeah, indeed. Okay, and then there's the question about follow-up action after discharge. Who'd like to pick that up?
Do you want?
No one.
Do you
want to do that, Jim?
To be fair, because Tara's only really just come into it. So in part, yes, we do follow up, but we don't follow up all of our patients. So there are two mechanisms at the moment. So if patients are discharged back into the community, but they're discharged home, then we have if they go into our crisis response team or on a home first pathway, they are followed up. I think it's 24, 48 hours later to just make sure that everything's okay and settled for them. That was a sort of recognising rapid improvement through COVID. Whether that's sustainable going forwards, that's an additional resource and additional cost, so we'll have to look into that. The CCG have also commissioned Health Watch to do a later follow-up and to check that patients, and I'll have to check the details, we can publish the answer to that, unless Lynette's already got it written down. I think it's day 14 or day 28, those arrangements are followed up as well. I think it would be really difficult to follow up every discharge. It would be possible to do that, but we would need to look at a business case to be able to pursue that, because obviously patients go into multiple discharge endpoints. So unless anyone else wants to add anything, that's sort of an initial view, but happy to sort of just check those time periods for who we do check.
Great. Thanks, Joe. So I think that's probably the best way of covering the questions that we've had submitted in advance, but I wanted to give Liz the opportunity to see if there's anything from today's agenda that she wanted to raise. If Liz is still with us.
I am still with us, but the technology tends to drop out a bit. I don't know whether others have problems. I just wanted to obviously refer to the Building for the Future and maternity, and very pleased that met with Jo Chadwick-Bell, and that she has agreed to look at the original case for change in 2008. And one of the main points that we have mentioned is the necessity for 2,000 births, which we believe is not absolutely essential. The number is not absolutely essential to get 2,000 births, but anyway, we're very pleased about that. We're in continual contact with Jo, and very pleased at her approach with the campaign group, and we hope it will be positive, with so much money being spent on a project which is, fit for the future. We believe that obstetric services obviously should be back in Eastbourne, but and we would also ask that there are independent people that are involved, and we've mentioned those people to Jo. But thank you very much, Steve. I hope you all have heard me, and thank you all very much.
Okay, thanks, Liz, and I don't know whether the technology meant that you heard the comments that Jo made earlier about, looking again at the numbers and so on, but not to raise anybody's expectation that will result in a change. In fact, if I can paraphrase you, Jo, I think you said we're going into this not with the expectation that there is likely to be a change. So people should not get their hopes up that that's what is inferred by the review work that you're doing. Would that be correct?
I think that I think that is fair to say, but I think that the expectation of the people of Eastbourne and surrounding areas with all the money is already expecting it to come back, because we've already had quite a bit of contact, and also with the have your say, people have said, you know, that's what we want. So I think the expectation is already there, unfortunately, because it's such a large amount of money, but appreciate that the board position at the moment is no reconfiguration of services. However, we hope that will change.
Joe, I don't know if there's anything further you want to add. I think we all know what each other are saying.
Yes, and I have spoken to Liz, and Liz has got a sort of statement, which a few of you have seen as well, of what exactly what I've said that she can share more widely. So I think we need to recognise the trust view and the say the DGH and wider public view may not align, but I think we'll leave that as that, and then we'll do the review and we'll restate things at that point.
Thank you. And I think just to say that we're very pleased with that approach, and can't expect more. Thank you.
Thanks, Liz.
Great, thanks, Liz, and thanks everybody. That brings us to the end of our public meeting. The next Trust Board meeting in public, Tuesday the 9th of February. So thanks very much, everybody. For those, so we're ahead of programme, so that's good. I think for those who are involved in the what was the 12:55 meeting, my suggestion is, unless anybody's got a problem with it, that we start at 12:30. We take a half-hour break to get some refreshment, and we start again at 12:30, if that's all right. Does that cause anybody any difficulties, any logistics problems? Lynette, anything I've overlooked in doing that? You're on mute.
I know, no, that's fine.
I'm mindful that we've got a couple of